Today, we're diving into a type of injury that is terrifyingly deceptive, one where the most serious damage can be completely invisible. We're talking about non-fatal strangulation, and really understanding its hidden dangers is absolutely crucial for saving lives.
So let's start with just a number, 50%. What do you think this could possibly mean for someone who's been strangled? This one statistic, honestly, it's the reason this injury is so incredibly dangerous for patients and such a challenge for doctors.
And there it is, a full 50%. Half of all victims will have no visible marks on their neck. No bruising, no cuts, nothing on the outside to show the trauma that just happened. This fact, which comes straight from the clinical guidelines, is exactly why we call this a silent injury.
And this leads us to the single most important rule of all. If you take away nothing else from this, please remember this. A clean neck with no visible injuries means absolutely nothing. It cannot and it must not influence any clinical decisions.
So how do medical teams even begin to navigate this invisible threat? Well, we're going to follow their roadmap. We'll start with how they first assess the patient, then go hunting for those hidden danger signs, figure out when it's time to scan, and finally, look at the vital steps needed to keep patients safe long after they've left the hospital.
To deal with all this complexity, clinicians can't just rely on guesswork. They have a very clear, step-by-step clinical roadmap that's designed to catch these hidden dangers before they turn catastrophic.
Okay, so here's the roadmap itself. Now don't worry about trying to read every little box. We're going to break it down. The first big decision is right there at the top. See how it splits? It separates patients based on timing and symptoms. Over on the right, you've got cases from more than 4 weeks ago with no symptoms right now. But we're focusing on that urgent pathway on the left. That's for anyone with a recent strangulation or who currently has symptoms. That's where the clock is really ticking.
So, if we follow that urgent path, the very first thing to do is absolutely critical. You have to go hunting for red flags. These are the specific signs and symptoms that tell you there's a high risk of a serious internal injury.
And this document right here, box B from the guidelines, this is the list of those red flags. You can almost think of them as tripwires. If a patient has even one, just one, like they're having trouble swallowing or they've lost some memory, it totally changes their treatment plan. It signals a much, much higher level of danger. The first group of red flags is all about the airway. Just a history of significant pressure is a huge warning sign all by itself. But clinicians are also listening for things like a hoarse or raspy voice, which could mean a fracture in the larynx. Or if someone has trouble swallowing, that could point to deep internal swelling that might just suddenly slam the airway shut. Next, you've got the neurological red flags. These point to potential brain injury, either from a lack of oxygen or from damage to the blood vessels. Questions like, did the patient lose consciousness, even for a split second? Are they confused? Do they have memory gaps about what happened? Are they showing any stroke-like weakness or seeing flashing lights? Any one of these is an extremely serious sign. And finally, doctors hunt for other, sometimes more subtle physical clues. Things like petechiae, those tiny little red spots on the skin from burst capillaries. They might listen with a stethoscope for a carotid bruit, which is an abnormal whooshing sound of blood flow in the neck. Even something like incontinence during the assault can be a sign that a major neurological event occurred.
Now, the presence of any single one of those red flags we just talked about, well, that triggers an immediate, non-negotiable next step in the clinical pathway. Finding even one red flag brings us to a simple question. Is a red flag present? If the answer is yes, the guidelines are crystal clear. There's no ambiguity about what has to happen next.
The patient needs imaging, and they need it fast, within 1 hour. The main recommendation is a CT angiography of the neck and head. This is a special kind of scan that lights up the blood vessels, so doctors can look for any tears, clots, or dissections that could lead to a massive stroke.
And hey, just as important as what to do is what not to do. The guidelines are explicit here. Ultrasound and plain X-rays are not recommended. They just aren't sensitive enough to spot these injuries, and that could give everyone a false sense of security with potentially deadly consequences.
But the care definitely doesn't stop with the scan. Even after the results are in, there are still 2 huge questions left. Is it actually safe for this person to leave the hospital? And what do we need to do to protect them from here on out?
A patient might need to be admitted for more than just a bad scan. Maybe there's still a worry about their airway, even if the scan looks okay. But this is so important. They also must be admitted if there's any doubt at all about their safety at home or if they're part of a vulnerable population.
This next step is absolutely vital, and it applies to every single patient, no matter what their symptoms or scan results show.
This document lays out the required safeguarding assessment. It's about looking beyond the physical injury. It's about ensuring the patient's total safety by talking about reporting to the police, checking their risk at home, and getting them connected with crucial support services.
The final phase of care, and it's a big one, extends way beyond the hospital walls. It's all about building a safe discharge plan that's going to protect the patient from long-term complications. You see, a safe discharge isn't as simple as just sending a patient home. It's a structured process with 5 key parts, all designed to protect them from the really dangerous things that can pop up weeks or even months after they've left.
So this plan includes, first, confirming their home situation is safe. Then, safety netting, giving them info on warning signs to watch out for. Arranging follow-up for vascular risks, which can actually last for up to a year. Assessing for an acquired brain injury. And of course, making sure their family doctor gets a letter to keep them in the loop.
So why is all this follow-up so incredibly important? It's because the danger doesn't just stop when the pressure comes off the neck. The most severe consequences, things like a stroke from a damaged artery or the subtle signs of a brain injury, can take days, weeks, or even months to show up.
Which brings us full circle, right back to the single most important message in this entire pathway. It is so critical, it's worth saying one more time. A lack of visible injury must never, ever be a reason not to investigate further if the patient's story or symptoms are at all concerning.
And this leaves us with a final and pretty crucial question. Knowing what we know now, that the deadliest injuries are often invisible and the consequences can be delayed, are we as a society really doing enough to see the unseen?